Good afternoon, everybody. We're just going to give everyone a chance to get into the webinar and then we'll get started. All right. Good afternoon, everybody. I am Kelly McDevitt. I'm the president of IBI. Welcome to our webinar. As those of you who have joined us in the past may know, we do research based on our IBI membership preferences every year. So we go out and survey our membership and ask what topics are keeping employers up at night. As you can imagine, this particular topic has been our #1 research topic for the last 3 years, and it will be again for this year, 2023. Obviously, the importance of supporting mental health in the workplace has been a #1 challenge for employers across the world for these last 3 years. And as we go through and into hopefully a post-pandemic workplace, supporting mental health and mental well-being is just a huge topic, both from an attraction and retention standpoint, and really just from a moral standpoint, that employers are wrapping their arms around employees and really giving them a much better basis from which to work from. So typically what we do is we go out and do our research with very large publicly available data sets. And we've done that in the past and had very successful research. But recently, what we've been trying to do is also support our research with actual data. So when we go out and use these large publicly available data sets, we are asking employees how you are doing, how you're feeling, how you're being in the moment. And you know how that goes. You can answer a certain way at a certain day at a certain time. But what we really want to see is then how that plays out in the real world. So on this topic of mental health, we were asking people these questions in surveys, in the research, but then we came behind it with our partner. We have a stakeholder board member partner, Elevance Health, formerly Anthem, who is supporting us today with actual claims data. We know what you said you were doing when we surveyed you. How did that play out in the claims data during the pandemic phases? And so our director of research actually ran this project. Candace is here with us and she's going to present the research. And then we have Kathryn from Elevance who's going to come in behind Candace and talk about how that played out in the claims data for the book of business claims data. And then lastly, we have Tara from Boeing, and Tara and I are going to have a conversation about real life examples about how an employer approached this and how they're going to continue to approach this for the future. So I'm going to turn it over to Candace and we're going to go through the research first.
Good afternoon, everyone. Thank you so much for attending. And the information I'll be presenting today extends our inquiry and provides an update from our report on mental health that was published in 2021. And we'll delve into some newer concerns brought on by the pandemic, such as remote and hybrid work, the heightened focus on diversity, equity, and inclusion, and the expansion of virtual care. And IBI will again be focusing on mental health later this year. So I welcome your comments in the chat, what you found informative, and if there's areas that you'd appreciate a deeper dive, please comment. We appreciate your feedback and we'll certainly take it into consideration. Okay. So I want to start by thanking our research committee who provided feedback and helpful comments along the way. Okay, so here are research objectives, and in addition to the points I just mentioned, I will provide a brief look at COVID and how it relates to mental health, and then I will be handing it off to Kathryn Caiazzo, our colleague from Elevance, and you'll see how the findings I'm presenting played out in the payer data. Oops. Okay, so the next few slides are methods, and I'll go through them quite quickly just to save on time. But this slide deck will be available afterwards for those who want this detail. So first off, for this study, we analyzed data from the Household Pulse Survey, which is an online survey conducted by the U.S. Census Bureau. The results I'm presenting today are representative of employed adults aged 18 to 64. And most of the results I'm presenting today focused on the period from July 2021 to August 2022. And then I've tried to add notes on the slide about other analytic details. Okay, a couple things I want to point out about measures. So my analysis focuses on symptoms of anxiety or depression. The symptoms are on the slide, rather than a clinical diagnosis of either anxiety or depression. And as you're aware, a condition like depression or anxiety can range from either very, very severe to mild. And sometimes people with mild symptoms or those with symptoms for a short time don't necessarily receive clinical attention. Okay, and so here are the sample characteristics, and again, the slide will be available afterward. Okay. A couple respondent characteristics I thought this group would be interested in. So on the left, we have employment sector, and you can see that most are privately or in the private sector, 63%, 14% in government, and then the rest in public sector, or I'm sorry, nonprofit and self-employed. And then we have on the right, we have insurance type. Vast majority have private insurance, 67%, 25% with public, and 80% uninsured. Okay, so now on to some results. Oops. Oh, sorry, technical difficulties here. There we go. Okay. Let's see. So I wanted to start with a 30,000-foot overview and show how much has changed since the height of the pandemic. So you can see that symptoms of anxiety or depression, or prevalence of symptoms of anxiety or depression, has decreased 5 percentage points since the height of the pandemic. So from 40% to 35%. However, the number of people taking a mental health medication has increased 2%, as has the number of people who report an unmet mental health counseling need. And now looking at where people are working, this data reflects a shorter time period. So the summer of 2022 from June to August. And we can see that the number of people working in person and those working remotely has flip-flopped. So at the height of the pandemic, 62% were working remotely, and now 61% are working remotely. And 17% are working in this sort of newer arrangement called hybrid telework, where they're part office, part working remotely. And then finally, while everyone included in this analysis was employed, some people were not working at the time of the survey because they were homesick, or maybe taking care of someone who was sick, or a child, or an elderly person. And this number has increased 5 percentage points. Okay, so now I have a quick update on virtual care use as it relates to mental health and COVID. And this slide shows that overall, both COVID and mental health symptoms are associated with recent virtual care use. So in addition to those with anxiety or depression symptoms, those who had COVID recently, or had more severe symptoms, those who had long COVID, or those who had COVID at time of survey administration, were more likely to use virtual care in the past 4 weeks. And while not everyone uses virtual care, and it's certainly not appropriate for every type of visit, these are some of the uses that we're seeing happening. And Kathryn will talk more about the use of virtual care in her presentation. Okay, so like most health conditions, the burden of mental illness is not distributed equally among the population, and this has ramifications for diversity, equity, and inclusion as it relates to mental health at the workplace. So first, you can see on the left, women are more likely to experience symptoms of anxiety or depression compared to men. So that's an increase or a difference in 5 percentage points. And then second, younger people are more likely to experience symptoms of anxiety or depression compared to older people. And for example, I recently also read an article in the New York Times discussing the high rates of anxiety and depression among youth and young adults. And this article proposed, based on some research, that these conditions, anxiety and depression, may be related to high exposure to social media, especially at such a young age. So, and these trends we see here will also be reflected in the data from Elevance and other areas. Okay, and now looking at sexual preference and gender identity and income. On the left, when comparing respondents who identified as LGBTQ+ to those who didn't, the LGBTQ+ group had a higher prevalence of anxiety or depression symptoms, 49% versus 34%, a difference of 15 percentage points. And then on the right, we have the effect of income on prevalence of anxiety or depression symptoms. And you can see that people with a lower income report a higher prevalence, and off to the right, people with a higher income, lower prevalence. And while this relationship has received less attention in the literature, there's certainly ample literature from other research supporting this finding. And here we have rates of anxiety or depression symptoms by ethnic category and household income. And I've divided household income into two categories to make it a little easier to look at. And you can see that among the groups who identify as Hispanic on the right, annual income makes very little difference in rates of anxiety or depression symptoms. In fact, those with a higher income are reporting slightly more, 1%. More, which is unexpected. On the left is everyone else, and they have the expected relationship. So those in the lower income groups have a higher prevalence, and in those in the higher income groups have a lower prevalence, which is what we would expect given the relationship I just discussed right here. Okay, and on to geographic distribution. So this slide shows the prevalence of anxiety or depression symptoms by state. And you can see that the rate varied from 41% in West Virginia to 30% here in South Dakota. Okay, and now on to some results regarding work arrangements. Here you can see that remote work, both hybrid and fully remote, are associated with higher rates of anxiety or depression symptoms. So the people working in households where everyone is working in person have the lowest rate, 35%, whereas those working in households with hybrid workers, which is 1 to 4 days working at home, and those working in households with remote workers, which is 5 or more days working at home, have higher rates, so 38 and 40% respectively. And I want to emphasize that, like the other results I presented, these results are adjusted for respondent characteristics. So that this means that the relationship between telework and mental health is the same regardless of age, gender, race, ethnicity, income, etc., as listed out, those characteristics listed on the slide. And I was surprised by these results. I personally enjoy remote work. I feel like it keeps my stress down rather than increasing it. So I went to the literature to contextualize these results. And I wanted to see what others looking at this relationship between remote work and mental health found. And we can see that overall, the literature shows mixed results in looking at the benefits of remote work, as some studies show that working remotely is linked to positive outcomes, such as less stress, depression, strain, etc., while there's some others that show increases in things like stress, burnout, and fatigue. And I think it's important to, remind everyone that the pandemic was a disruptive event. And that everyone was all of a sudden working at home, whether they wanted to or not, whether they had the support that they needed or not, as far as equipment, internet connection, etc. They may not have known how to get the social support they needed from their colleagues remotely. They may not have had the space at home. They may have had disruptions or less than ideal conditions for work at home. And the second review, I feel like, pointed out some of that. The articles that were published before the pandemic mostly demonstrated positive effects of telework. whereas those conducted during the pandemic, which provided evidence for mixed and even negative results. So I think this is all still developing. And as we all know, and have seen in the news, some employers want their employees back in the office, others don't, and others are experimenting with various hybrid schedules. So I think this will continue to be an interesting topic for some time.
And Candace, stay on this slide for a second. So, I think that for those of you who are employers or who advise employers on this call, that this is a very hot topic of conversation. The return to office strategy right now is very difficult for some employers to wrap their arms around, especially dependent on their culture and their employee makeup. And I think that the problem, and this is going to be separate research for us because it's such a meaty problem to dig into, but I think that the easy answer, and Tara and I will discuss some of this when we talk at the end of the webinar, is that I don't think there's a one size fits all solution here. If you think back, and this number that you see in the second bullet, 79% pre-pandemic demonstrated positive effects of telework. Well, when you had to apply for a telework job pre-pandemic, you had to demonstrate that you had the personality, the skills for organization. Sometimes you had to work in the office first before you were allowed to work at home to really prove that that was a good environment for you. You had to prove that you had childcare at home, that you had the right equipment set up, that you had a quiet place to work. And so it was almost like you had to earn the right to work at home. Then the pandemic hit and we just said, everybody go home. So I guess that the point here is that just because someone can work at home, is able, and someone wants to work at home full time, doesn't mean they should. It doesn't mean it's good for the business. It doesn't mean it's good for the person. And what we want to start discussing is how you meet your business needs as an employer, but also meet your employees' needs, not only from a production capability standpoint, but from a personal standpoint. So this is a very meaty topic, and we totally realize that we need more research on this whole, return to office strategy and what's best for most and what's best for all, maybe two different things. And it may not be one model. So thanks, Candace, for highlighting that.
Absolutely. I agree. Okay. So moving on, next I looked at symptoms of anxiety or depression by work status and found that those who are not currently working, you can see the reasons at the very bottom of the slide for people who are not currently working the previous week before taking the survey, were more likely to report symptoms of anxiety or depression. So there's a difference of 10 percentage points in the graph on the left. And then on the right, you can see, I also found that not working modified the relationship between many individual characteristics that are often related to mental health and that we expect to be related to mental health. For example, the relationship between gender and anxiety and depression. As I'd mentioned earlier, women are more likely to experience anxiety and depression symptoms. But when we looked at people who were not currently working, actually men had slightly higher rates of anxiety or depression. So it's 44% versus 43%. And those who are currently working had the expected relationship. And I'm not able to present it today. I don't have time, but I just want to kind of give a plug for the report that is out and available on the IBI website for members. And I think it'll be available in 3 months for non-members. I found a similar reversal of expected relationships between those not working and those currently working. So such as income, regardless of income, those who were not working experienced higher rates of anxiety or depression across the board. And enhancement of the positive effects of having kids in the household. Okay, and so I just want to provide a quick look at the association between COVID-19 and mental health. So here you can see how COVID relates to mental health, and you can see that those who had COVID recently, those who had more severe symptoms, had long COVID and had COVID at the time of survey administration were more likely to report symptoms of anxiety or depression. And so I think it's just sort of a, perhaps what we're seeing with anxiety and depression is to some degree associated with COVID itself. So I think you'll see this relationship mirrored in the data from Elevance that Kathryn is presenting. And at that, I will hand it to Kathryn.
You have to unmute, Kathryn.
Sorry about that. I need to go back a couple slides as well. Almost there. Okay, thank you everyone. And thank you so much, Candace. And on behalf of Elevance Health, we are just so appreciative of this opportunity and the invitation to present alongside IBI today. Really happy to be here. So thanks so much. Again, my name is Kathryn Caiazzo. I'm a registered nurse and I work with the data and analytics team here at Elevance, who helped to pull this data together. I also work very closely with our behavioral health experts who guide our clients and inform our clients on the behavioral health experience and the offerings available at Elevance. So thank you to all of you who are on the call here today. We really appreciate the time. I just want to mention that the claims data I have covers some of those changes that we saw and continue to see in the behavioral health condition categories of anxiety, depression, and substance use disorder during those pandemic months. So we're really focused in on those same months that Candace looked at. And as Kelly and Candace mentioned throughout the presentation, we wanted to see what similarities or differences we could appreciate in the claims data compared to some of the research that Candace just went through. And before I start to share these results over the next 10 minutes or so, something that I want to mention is that the member data here means so much more than just data and trends. This is a reflection of our members' experience, and we take that very seriously and carefully at Elevance. And so these aren't just numbers on a page that I'm going to talk about. This is our member experience with depression, anxiety, and substance use disorder. And so I just wanted to make mention of that. Try to advance my slide. Okay, here we go. So, I just want to quickly share that this data is analyzed in the same kind of way that Candace went after the data. We're looking at those months inclusive of the start of the pandemic compared to those months through August of last year with a couple of months of run out. The population that we looked at in our analysis include commercial members. We excluded any Medicare, Medicaid, retirees, or individual business. We also excluded any accounts that don't, or clients that don't have any behavioral health coverage. Sorry for the delay in the slide change here. Real quick on this page, I've included some high-level info looking at the results. And first off, I just want to mention that we had 6 million members, over 6 million members in both the prior period and the current period. And so that's a really good representation and a lot of data to work with. So our current period shows 9% of members had a diagnosis of depression and anxiety. 17% of our members filled an antidepressant medication, and 41% of our members said that they were stressed. I'm going to come back to these figures as I walk through the next slides. Okay, good. We're changing a little bit quicker now. So starting with some really broad brushstrokes here, what I'm showing you is that from prior period to current period, looking at member rates and visits per thousand in the condition categories of anxiety and depression and substance use disorder, we've got some increases. So the blue bar represents, the light blue bar rather, represents the prior period. And here we're looking at depression and anxiety on the column chart to the left. So we've got a percent change of 9.5% in depression and anxiety and 9.2% increase in substance use disorder. Visits per thousand, we also saw those going up. So we have a 12.5% increase for depression and anxiety on visits and a 2.1% increase in substance use disorder. So, I doubt this is, a big surprise to any of you. And maybe some of you might be thinking, wow, I would have thought there were even greater increases. And some of what we can all appreciate is that we're starting to see, and we're seeing and analyzing some of that rebound care from the prior period of foregone care. Also, we know that behavioral health year over year increases can be significant when looking at our clients' data. And some of the thoughts and questions that I have, and go back to what Candace covered in the beginning as objectives, are when we're considering these increases, when we're looking at the behavioral health condition categories of depression and anxiety, I think about, have we opened the door for access and alternative care settings, such as virtual care and telehealth? Is that, a viable option for these conditions at this point? Are there other factors surrounding the pandemic months? So factors like stress and illness and job loss. Candace talked a little bit about those. I'm going to talk about those as well. And as a healthcare ecosystem, have we reduced any stigma? Are we doing a better job with allowing people to come forward and to seek out treatment? And so this slide is looking at the population, and I go again, like I take the statement of stigma and I bring it right in here. So as Candace mentioned, and as you can see on this slide, that we've got a significant more females seeking out care for depression and anxiety in comparison to their male counterparts. So very clearly here, you can see that females are seeking out care, and there are more females just accessing the care. The percentage change from prior period to current period is showing that there are a few more males seeking out care than there are females, as this percentage change shows here, a 10.1% increase for males. This age graph here is interesting. So as you might all, as you might have guessed, and as you can imagine, some of the younger generations are having more difficulty with anxiety and depression than our older generations. So no big surprises there, but I think it's an interesting point to call out and something that we all need to dig into. So there are these percentage changes up here that kind of jump off the page a little bit, and certainly the under 18-year-olds, we know and we hear about, and Candace mentioned this as well, some of the challenges that teens have right now. And so I think this is a area that we are all interested in exploring more at Elevance. We're deeply concerned, and we want to help to address the problems that we're seeing in some of the younger ages for depression and anxiety. All right. Okay, now let's talk a little bit about settings of care and specifically access. So COVID really fueled the need and desire for virtual care. I think we all experienced this in one way or another. I know that I had several telehealth and virtual visits over the last couple of years. And I also had a few with my kids. And so as this slide states, virtual care soared. So if we step back into the prior period, and we're showing that here on these charts, This prior period is representative of that time around 2019 before the hit of the pandemic. And we see that we were using virtual care pretty minimally, right? We had pretty low rates of virtual care for both behavioral health telehealth membership and medical telehealth membership. So we're showing both the medical and the behavioral health here on the slide, and on the left-hand side is specifically the behavioral health membership per thousand utilization. You can see how that skyrocketed in the prior period, going up significantly and hitting 2020 with a visit rate per thousand, or member per thousand rate of 50 members per thousand in the prior period for behavioral health. That's in comparison to, and more specifically, depression and anxiety. And that's in comparison to the chart on the right-hand side, where we're seeing, you know, the peak here is showing 20 members per thousand having reached out with their medical issues, using virtual care to treat or to address some of their medical issues. So just very interesting to compare the medical, those folks who are seeking out care in the medical space versus the behavioral space, and the behavioral space really showing that members were accessing care in this kind of way. All right. We do, I also want to mention before I advance to the next slide, we are starting to see some of that drop. Certainly not to the levels of the pre-pandemic or 2019 and back, but we are starting to see some of that telehealth and virtual care kind of come down. And I'm just going to dig into those visits a little bit here. So like I mentioned, for depression and anxiety, are seeing a little bit of a dip, 8.9% of a visit rate coming down year over year. And then for substance use disorder, again, a little bit of a dip. And, you know, we can think about some of this as, you know, return to in-office care. Also, we might consider that there are a lot of other ways that folks are accessing care for their behavioral health issues. There's a lot of apps out these days, and a lot of, I would say, activity outside of the claims, the claim system and the insurance world.
And Kathryn, before you go on, I just want to make a quick point about telehealth for behavioral health. We did a research project last year on telehealth in and of itself. And one of the probably key pieces of data that we took away from that research was that while many employers use large national vendors as a solution for telehealth, most of the volume, over 85% of the volume, in fact, of telehealth that took place during the first 18 months of the pandemic was with people's regular providers. So PCPs and specialists who had stood up virtual care, if they hadn't had it already, due to the pandemic. And that, I'm not saying that's a bad thing. It's actually, I think, a good thing. Staying with your medical home, the providers who know you, that have access to your chart, can only be good for outcomes in the long run. Now, that's the medical telehealth. When you look at the behavioral health telehealth, while the medical came back down to, probably a little higher than pre-pandemic levels, for a long time, behavioral health telehealth did not come down. And as Kathryn just showed, it's staying higher than it was pre-pandemic. The question for employers now is, what is the right answer? We know that telehealth is being put in as a solution, apps, all online virtual care for behavioral health. Is that the right solution? So I think what employers have to be really aware of right now is their data. Are the vendors that they put in the last 36 months, perhaps those are apps or tracking mechanisms, do you have enough data to know if your outcomes are clinically positive? And that's where we're struggling right now, because as Kathryn alluded to, maybe an employer put in Calm for free for their employees. And that's a great app. But mindfulness is something that has been well documented to show improvement in symptoms of anxiety and depression. However, getting data back from some of these virtual solutions is very difficult. And then measuring that data to a positive outcome is even more difficult. So we realize that there's more research needed in this area, and that we as employers moving forward need to be really cognizant of the type of data that we're able to look at from these vendors. So thanks, Kathryn, for highlighting that.
Yeah, thank you, Kelly, for all those comments. Completely agree. So this slide that I have in front of you is again showing that while our utilization, is coming down a little bit from the prior period to the current period, we're not seeing it return to that of pre-pandemic, nor are we seeing the behavioral health conditions returning or decreasing as much as the medical conditions. And so this is showing simply, if you look at the depression and anxiety percentage change, we've got a decrease of 13% from prior period to current, in comparison to, say, maternity, which has come down 26%. Just a little more detail there. And then lastly, on telehealth and access, I just wanted to talk a little bit about where members are located that are using telehealth. So the first column graph on the left-hand side is just kind of straight up showing where members per 1,000 are, those members with depression and anxiety, and those members with substance use disorder, where they're living. And then layer on top of that, the telehealth utilization for those members. And that's the column graph on the right. And I think it's really interesting to look at the rural areas, how we're seeing kind of such a decrease in the utilization for members that are using telehealth in the rural areas. This is an area that typically we see, we have a hard time with access, and sometimes we really struggle with services. So it's just interesting that, our telehealth and virtual utilization isn't staying a little bit higher in these in the rural space. Okay, I'm going to switch gears a little bit and moving from virtual and telehealth into prescription medications. And as we know, prescription meds can be a good, effective treatment for those folks with depression and anxiety. And this slide is simply showing the increases of members filling prescriptions from the prior period to the current period. Linking that back to, what I've talked about thus far, and the increase in visits, the increase of members for both anxiety and depression, we know that members were receiving treatment plans, and treatment plans including medical and prescription management. So you can think about, what we just talked about in the virtual care environment, and how we saw those significant increases in behavioral health, specifically anxiety and depression. And along with that, along with those virtual visits was the treatment plan, inclusive oftentimes and sometimes of prescriptions for anxiety and depression. Okay, I have just 3 slides left, and so I'm going to shift here and talk a little bit about compounding factors related to behavioral health. And the first one we're looking at is those members who self-reported stress compared to those members who self-reported having no stress. And, again, no big surprise here that we're seeing member per 1,000 rates much higher in the group that reports stress, as opposed to the group that reports no stress. And very similarly, on the visits per per thousand, showing those members who report stress having more visits for depression and anxiety compared to those members not reporting stress. Okay, and this one here, this is interesting. We wanted to look at COBRA as, you know, Candace talked about the research and digging in a little bit to the unemployed population. We wanted to understand, you know, were there any differences between those members who elect COBRA versus those that population of folks who don't have COBRA, and we can see here there's a little bit of a difference, right? So we've got members per thousand in the COBRA in the COBRA category at 96 per thousand in comparison to the non-COBRA category at 88 per thousand. And then we've got visits showing very similar like numbers, visits per thousand being higher in the COBRA category. So using this as a proxy to some of the unemployment data that Candace looked at, very similar. Okay, and this is my last slide. And looking at COVID and the direct association of COVID, the analysis is just kind of showing that we have more people who have a diagnosis of COVID also being diagnosed with anxiety or depression compared to those folks who do not have a diagnosis of COVID. Again, not a big surprise that illness and certainly COVID can lead to other complications and potentially a struggle with depression and anxiety. And really just kind of reflective of some of the research that Candace brought forward today. So that completes my portion of the presentation. Again, we really appreciate the opportunity to present with Kelly and Candace today. Thank you for inviting Elevance Health in, and we look forward to working together.
Thanks, Kathryn. What we're going to do now is I want to, first of all, take some questions before Tara and I talk about how Boeing approached this particular challenge. And I'm going to do my best to get to the right person with these questions, if I can. Either Candace or Kathryn. The first came in regarding the claims data showing outpatient visit rate change. How did you address the provider and patient community's feedback for decreased access to insurance paid service, with some percent of those visits converting to cash pay? Would you assume any additional percent change in one direction or another? So first of all, in both, and this applies to a few of the questions that came in both the research that IBI did and the claims data that Kathryn was showing, these are all employed, covered by insurance employees. So those that were surveyed and those that are obviously in the claims data that Elevance provided coverage through their employer. So we did not have feedback from the provider community at all, only the feedback from the patient community. And there was nothing in the survey data that asked about, was this, in the surveys, we were asking about people's symptoms. And in the claims data, those are people who are all covered by insurance by their employer. The next question is probably to Kathryn. Do we have any data around why substance use disorder is low? I'm not sure we do think substance use disorder is low. If you want to retype that question, it certainly hasn't gone down, but maybe you mean why it's lower than anxiety and depression. So I'll let the person who posed that question go ahead and maybe retype it with some more detail around what they're looking for there. There's the next question. Why are telehealth visits dropping? Is it access? People who just gave up? Apps cannot be compared with an actual visit. And should we assume that's where they went, back to an actual visit, where stressors really dropped? I would say based on the research that Candace did and the claims data, I think that telehealth, because we had such a huge spike at the very beginning of the pandemic, and obviously at that point, doctors' offices were closed, I would say that that was an unrealistic spike and couldn't be sustained over time. So quite frankly, we would expect it to drop. I do believe, and we're actually doing a separate research project on delayed care. I do believe that people are returning to care. Actually, most people are returning to care in person, which is great. I agree. Going to a virtual visit where you don't know the doctor, they don't know you, they don't have your chart, is not a replacement for in-person care. So I would say that a good percentage of these people actually return to in-person care. But what we're seeing in the delayed care project is that not everyone is returning to care. And it's for many different reasons. Those you could probably guess at. SDOH concerns, financial is a huge one. Access is still an issue. So especially in the behavioral health space, we still have access issues far and wide across the United States, not just rural areas, but even in big cities where providers, don't take insurance, we still have access issues. So I think that we'll continue to see this more of a leveling off rather than a drop of telehealth visits, leveling off for some time. Although in the behavioral health world, we're going to need virtual care where we do not have access, both for different groups of people, both for financial reasons and because in some areas there's just not a reasonable amount of time to drive to get one who is taking new patients or has appointments open. So more to come on the delayed care project. You will see more answers definitely about virtual care. Let's see. Oh, good point we had from Nina on telehealth about the early days of the pandemic and that huge spike was that we had both government and employer guidance on waiving cost share for telehealth. And now a lot of those are being wound back, right? So employers at the very beginning of the pandemic felt that they needed to waive copays for telehealth because people couldn't access care any other way. And so as we go on into post-pandemic or endemic phase, many employers and some of the government assistance that we had around COVID benefits have gone. And so we're back to regular plan design at this point for telehealth. Let's see. In regards, here's another question. In regards to depression, were you able to delineate Elevance members who were suffering from mild, moderate, or major depressive disorder? That's a really good question. And Kathryn, correct me if I'm wrong, but I don't think we categorized. We lumped together all the sort of depression categories under that ICD-10 category. But
That's
certainly
correct.
that work could be, we could break those out at the ICD-10 level, correct?
Yep, we sure could.
Okay, great question, Mark. Mark's second question was, within the anxiety and depression claims data, were you able to access the costs associated with the prevalence? Yes, the answer is yes. We have both cost and utilization, correct, Kathryn?
Sorry, yep. Yes, we do.
Yep, we have both. Elevance members, stress. What kind of instrument survey was used to elicit this? So Fred, in the Elevance claims data, they weren't reporting stress. We got claims with ICD-10 codes related to depression or anxiety. So if it had an ICD-10 code with the depression or anxiety category, that's what we used for the Elevance claims data. Also,
yeah, sorry, Kelly, I'll just jump in there. And we also did access our HRA survey.
The HRA survey. I'm sorry. Yes, that's what Fred's talking about.
Yeah, so we did, Fred. We accessed the HRAs to give us those stress numbers.
My mistake. Sorry, Fred. Okay, let's see. Santiago asks, is there anything employers can or should be doing to reduce stress and reported anxiety and depression? We're going to talk about that here in a minute with Tara. Okay, let's go on to our discussion. So We're back to the regular screen. Here is Tara Sherman from Boeing. I will let Tara introduce herself, and then Tara and I are going to have really the discussion around what in the world do we do now, and how has Boeing really approached this, both from a historical perspective and the way that we're looking forward in the future. So Tara, go ahead and introduce yourself.
Okay. Hi, everybody. My name is Tara Sherman. I'm with the Boeing Company. I work out of Chicago, and I've been working in the mental health and well-being space for about 10 years now. But the kind of interesting background that I bring is less of the clinical expertise and more of the HR side and working with employees and leaders on a daily basis. So it's been a really great combination of bringing the work together. And I'm really happy to be here today with all these experts and chat with you, Kelly.
Thanks, Tara. So I think that obviously, employers have been really stuck, and specifically HR folks have really been stuck in this place since the day the pandemic began, of creating a new role and a new responsibility, really even a new social contract with our employees, right? Pre-pandemic, we as employers felt an onus on us to provide good, sturdy benefits with great programs to support their health and well-being throughout. And Boeing obviously has always had a fantastic track record of offering a very rich benefit plan to do that. Some of these things that we're talking about aren't new to large employers like yourselves, but what the pandemic did was turn HR folks like yourself into infectious disease specialists and purchasers of safety equipment and testing, and probably more importantly, brothers and counselors and priests and friends that you really never stepped into their space before, because we were all suffering together at the same time. And so I think employers on the whole did a fantastic job of stepping into that role and saying, we need to provide better support from a well-being perspective, especially for those that we just sort of talked about earlier that we just sent home. Said, here you go. We'll still stay with you, but it's going to be from a long distance. And how employers really address the support of one's mental well-being while you weren't in the office together. And so I want to talk about, first of all, how the pandemic changed how Boeing approached the benefits strategy, and knowing that at the time, think about back in 2021, when you were designing your benefit program for 2022, we didn't know where we were in the pandemic. We didn't know what was to come still. We were still dealing with spikes up and down, new variants, et cetera. Looking back at your behavioral health benefits and programs pre-pandemic to that point in time in 2022, when we were really stuck in the middle of it, how did you change your approach? How did you change the way you thought about behavioral health benefits?
There's a few things that you said that connect right into it. So one was the social contract. I think that we were a little bit ahead of the game in our focus on mental health as a priority. So we had good benefits and resources in place for our employees. But then all of a sudden, there was this complete emphasis on mental health because we were all thrust into this situation. And quite frankly, this discussion is bringing me right back to this time 3 years ago. And we were all suffering as a world. It's the only time in my lifetime that it has been not a country suffering, but a world. And that social contract became that not only did we have to provide the benefits, but we needed to provide education. We needed to build awareness for people on what they were experiencing and how they could help themselves, and for our managers on how to support their teams when they're going through all of this at the exact same time. And so right out of the gate, something we did that we're still doing is a heavy emphasis on communication and awareness. So we started doing something called well-being hours that was heavy focused on mental health. It's since expanded to lots of areas of well-being, but we did mental health 101. We did sleep sessions. We did a session on how to find a good therapist match. And we brought in experts from our supplier partners, and I really specifically say partners because those organizations that we work with are really just lockstep and part of our ecosystem to make sure that we're giving employees the best care that we can. But our employees had the chance to learn from experts, to ask questions of experts, and the conversation that happened was so encouraging. We did add from our telehealth provider virtual therapy. And then a little bit into that, they actually developed a virtual adolescent therapy program, which was so meaningful because that's something we had been looking to fill for years. And I say the only thing harder than finding a therapist is finding an adolescent therapist out there. And so we're really happy to be able to bring that. Also, our health plan, again, talking about the contract and making things easier for employees and really providing that wraparound support, stood up a navigation service so that our employees could call in, and our partners at Blue Cross Blue Shield would do the work to find a therapist that matched the employee's needs. That could be, sometimes it could be ethnicity, it could be gender, it could be LGBTQ competent, and make that first appointment for them. And they added then another layer, which is calling back to check and make sure it was a good match. And if it is, great. And if it's not, finding someone additional. One last thing I want to add that we've done, just because I think it was such a big movement culturally, is telling employee stories. The first employee story that we shared of someone's mental health journey was one of our male executives. And the title of it was, it actually makes me a little emotional. I was curled up on the bathroom floor. And that is not a way we've ever communicated in corporate America, at least in my experience. And the outpouring of response from that individual being brave enough and courageous enough to share their story, he received a ton of support, but there was also so many comments recognizing that I've suffered, you're not alone. Now we know we're not alone. And it really set up, we've received more employee stories than we actually can share. People want to talk about it. They want others to know how they got help and that they can too. And so those are some of the things that we've done. And I think how things have changed, because that stuff wasn't all out there. It was more like, we want to make sure we provide their, coverage. We want to make sure that it's accessible. Yeah.
So you said so many things that are cool, and I think really right on the right track for what we're going to need going forward, because this is here to stay. I will tell you personally, I remember 10 years ago sitting with large employers, and we'd go through a QBR every month, and we'd review your medical trend and your pharmacy trend, and we get to the mental health section of your giant deck. And a lot of employers would be like, well, we don't have a lot of time right now, and that doesn't cost me a lot of money, so let's just move on to the stuff that's really driving trend. No more. We're done with those conversations, right? We are all now at the table and aware of what's really going on. And so I think these conversations around not just cost, but what it's costing personally for both your staff and the employees themselves is huge. And even from a productivity perspective, if you are anxious or depressed and not getting care, not having access to care, you are not performing at work. We know from our research at IBI, the absenteeism, presenteeism view of folks who have anxiety, depression, or other symptoms and aren't being dealt with is huge. And so if you're not paying for it on the medical side, you're paying for it on the productivity side, believe me. So I'm so happy to hear about, first of all, the stigma removal. I think one of the questions in the chat was around, what do we do, from here? I would say that out of all the topics that we've addressed over the last 36 months regarding behavioral health and mental health support, stigma removal is probably number one, because you could have every product and program available to mankind out there for your employee base. And if they're afraid to stand up and say, I'm not okay, it doesn't matter what you're offering them, they're never going to access it. So when we talked about some of the data, like the substance use disorder, for instance, statistics seemed quite low. There's still quite a lot of stigma around that, especially for the male population, to stand up and say, I've got a drinking problem, I've got a painkiller problem, etc. So if you don't get to that kind of first thing first, removal of stigma and that it's okay to say you're not okay, your products and programs can't be successful. So I love that Boeing addressed that right out of the gate. We are all in this together. And speaking personally from having a family member with anxiety and depression disorder, it's hard to stand up and do that. But once you have, and you realize, as you said, Tara, the community that's out there that can share in that with you and pass the word and pass the good word about it, because there is good news, the better off you are. The second thing you talked about that was, I think, extremely important, and in my case was the case, trying to find adolescent behavioral health care is not only extremely frightening when you're in the moment, but much less accessible for adolescents. And so having a navigation partner or a behavioral health program partner who provides that navigation is extremely important. As a parent of a child with those disorders, you don't know where to turn. And I'm in the insurance industry. I know a lot of people and still struggled mightily to find the right providers. Having that sort of navigation is just a huge step in providing that kind of support for your families. I want to talk about now the idea that education is a huge part of this, not just education around the stigma itself, but think about, for those who have returned to work in some form or fashion, whether it's part-time or full-time, back to the office, how do you help supervisors and leaders, even the C-suite, understand what your population needs? And then when they see it, how do they recognize it? You know, thinking about in a manufacturing environment where you're, making planes and things, and, a supervisor sees Bob standing there and knows that Bob is not okay, but I don't know how to approach Bob. I'm not a professional. How do we support our leaders, both from the C-suite all the way down to supervisor and frontline managers, to help them get people to the benefits that are available to them?
So I want to start off by saying, I don't think we have this solved.
Yeah, we do. We definitely don't. We don't. None of us do.
Yeah, we're chipping away at it. And so I think by sharing the employee stories, that has been huge for us to just bring the conversation in. It can still be very intimidating as a supervisor, a coworker, to try to broach the conversation. So we have done some training for managers through EAP on recognizing signs. We have just recently started a mental health ally program, which I wish I could take credit for the idea for, but Target, Delta Airlines, some others have been doing these for a while. And that is more about training peers, so and managers, but it's available to anyone on the resources. But it's been more and let's get these resources out there so people know where to go, and it's a trusted peer versus their manager or HR, depending, different relationships. So I think that we've still got a lot of work to do around the approach. We have culturally something we've been doing called Seek, Speak, Listen. It's been a big initiative that came in during early in the pandemic for both some business needs, and then it quickly was also very helpful during the pandemic, but kind of seeking out how someone is doing, or if someone is feeling different, and them knowing that it is safe to speak. So really increasing psychological safety too. And that person listening. Now then, I think the big concern for managers and supervisors is, oh no, what if I learn something and I don't know what to do about it? And so that's where the outreach on resources has become really, really important for us. And I think for anyone in an HR role or a benefits role, sometimes we beat our head against the wall because we feel like all we do is communicate. And then it feels like every day someone says, this is a great benefit. I didn't know you had it. And so it's twofold. It's helping make sure people feel comfortable just asking a probing question or two. And at the same time, then having something in their back pocket to offer.
I think that's awesome. And one of our folks in the chat asked about mental health first aid. I can't talk enough about mental health first aid because not every employer is a Boeing and has a big HR team. Not every employer has EAP programs. Not every employer has the wherewithal or the money to pay for, buying a new mental health telehealth program, et cetera. And so mental health first aid, it is something that we all have access to, and I think is just a great educational tool. So Sally, thank you for that suggestion. And I think we would all agree it's something that we should have, I think, at every work site, just because it's a great piece of education for folks who don't know a lot about this. And we have a lot of people in America who still don't understand that mental health is actually a diagnosis, behavioral health problems are diagnoses, and that people can be helped, and there should be no stigma attached. So we love mental health first aid. So thanks for mentioning that. Tara, we have a question from Fred about, and this is a great question, subclinical care, like peer counseling, et cetera, which you just talked about, the peer counseling piece. But does Boeing offer any other subclinical programs like mindfulness, stress reduction, those types of things?
We do. Yeah, we do a lot with that. So the first thing I'll touch on is coaching. Because for several reasons, it may be the best match because they may not have a clinical need. We also saw mental health coaching as a really good way for someone, because no matter what we do to try to reduce stigma, there is still a little bit. And that we saw that as a very smooth entry point. So someone may say, oh, I'm really stressed. Oh, coaching for stress, sign me up, versus should I see a therapist? I want to think about that a little more. So coaching is something that we have used very effectively. The other great thing about the provider that we happen to use is they also offer a variety of programs in physical health. And we've seen such connection between improvements in both physical health areas like weight or blood pressure when it's addressed concurrently with mental health needs. So that's really a biggie for us. And then we also do have a more of a resilience program in place. It's more focused on brain health, but in there are neurotunes for employees to use. There are meditations. Through EAP, we actually host about 15 or 20 live meditation sessions each month that people can sign up for. So I'd say those are probably the key areas where we try to impact on a subclinical or more proactive way.
Yeah, those are all really great. And I think more and more employers are starting to understand that just like if you had a low back pain issue, doing stretching exercise and back exercise and really that muscle memory, that applies to mental health too. So there are other things that are subclinical that can really build a basis and support system for those who suffer from mental health conditions to make them stronger and more resilient. That doesn't always have to be counseling or inpatient or prescriptions. It sometimes can be, these subclinical programs can be very, very effective. Another question from the audience. They love having access to you, Tara. Mark asks or says, I applaud your focus on mental health and the courage of Boeing employees willing to share their personal stories. As other Boeing employees voiced their struggles with mental health, were there any changes that you made in your pharmacy benefit to minimize barriers to therapeutic options and improve access to medications that they need? Or did I'm going to guess you already had looked at those barriers previous to the pandemic, but tell us about any changes that you might have made with your pharmacy strategy.
Yeah, so we haven't made changes, and I'm not aware that there are barriers currently. That being said, I feel like I learn new things every day. But one area that we are really trying to learn more about is the genetic testing for mental health drugs. There's not a ton of coverage yet for those tests. And something that I personally believe pretty strongly about is if the data can show that it's helpful, that is something that would help our company, our costs, and most importantly, the individual, because we hear stories over and over that it can take people, two times, 3 times, the 4th medication they try actually works. And if we can get ahead of that, and we know that option 1 and 2 are not likely to work for this person, we can relieve that suffering, the time, the appointments. And so although I can't speak to a lot of changes we've made specifically already, that's something that we're heavily considering. And yeah, hopefully I'll have an update for in 6 months or so.
Yeah, so I will speak to that personally. PGX changed my life and my son's life. As we got further down this road of trying to find clinicians and treatment available during the pandemic, what we learned very quickly was, and you'd think I would have known this being in the insurance industry for 40 years, but I didn't, that it's a spaghetti against the wall approach when it comes to medication, and for adolescents, even more so. And so we really, at the time, I didn't know anything about PGX. I knew that there was genetic testing out there, but I didn't know that it was specific for behavioral health drugs. And so after trying, the first 10 or so, and, you meet with a psychiatrist literally for an hour and you're prescribed. You can't learn about someone's behavioral health issues in an hour. You just can't. And so when we discovered PGX, really, I went out to the marketplace to my friends that, high up in different pharmaceutical companies and at pharma themselves, and said, does this work? And they all resoundingly said, absolutely do it. And at the time, we worried about cost, because when PGX, I think, first came to be, it was expensive. And as a large employer, and thinking about, if I paid for this for everyone who was prescribed a behavioral health drug, it could have been cost prohibitive. It is not so anymore. It's very reasonable. And like you said, Tara, if you take away, PGX doesn't tell you what drugs you should take. It tells you what drugs you shouldn't take, or that probably will high likelihood of not working for you. When we did that for my son, what we found was that 3 out of the 5 drugs he was taking, he shouldn't have been taking. If we had known that off from the beginning, we would have, saved ourselves 8 weeks of no effectiveness from the drugs. Yeah. So I am 100% behind you looking at the PGX coverage and rolling that out. Okay. Let me just check for questions. Yeah. So Mark just said what I said. Looking through all the other, I think we've answered everything from the audience. I'm going to put one last call out there to the audience for any other questions you have for Tara or myself or Candace and Kathryn. So I want to talk about now what's next. So I think we're all trying to really look around the corner. We've already created this base, I think, that employers can start from: reduction of stigma. Quite frankly, I think that most employers right now, and I know you didn't have the need to do this because you were ahead of the curve pre-pandemic, but most employers really need to relook at their behavioral health strategy. They really do. First of all, they need to look at how they're going to reduce stigma and satisfy employees from attraction and retention standpoint with the programs and products that they offer. What the 25-year-olds of the world want are not what the 55-year-olds of the world want. And so you really have to know your population. I dare say we might have to go back to segmentation and looking at the personas that live within our employee workforce to understand their needs, ask them what their needs are. And then I think also re-looking at your behavioral health strategy. I saw many employers just move their EAP from 3 visits to 5 or from 5 to 10, and that was it.
Yeah.
Well, let me just tell you, if your EAP program wasn't being utilized pre-pandemic, it's not going to be utilized now. So take a different approach. Yeah. Take a different strategic view. Ask employees what they need and what they want and how you can provide that. But I think at the real core of this is access to all. First of all, you really need to start thinking about the right provider for the right person. I think this is where Tara touched on the program that they're running, really connecting to the right provider at the right time for the right person. That is huge, because if you finally get to someone who is willing to say they have a problem, raise their hand, they're ready for treatment is the appropriate option, and then you can't connect them with a provider that's going to work for them, you've just wasted a lot of time and energy, and the person isn't going to get a good clinical outcome. So really that navigation piece, connecting person to the provider that will be helpful for them, and the type of provider. Not everyone needs to see a psychiatrist.
Right.
Not everyone needs to see a psychologist. There are different levels of care for different diagnoses. It's just finding that right match that is very important. So I guess my question for you, Tara, and this is a crystal ball question. Now that we've learned all we've learned, and I think, first of all, I want to applaud Boeing because you've always been, this was pre-pandemic, back many years ago when you were my client. You've always done a fantastic job of listening to your employees. And when they bring you things that are hot items that need to be addressed, I think you've done a fantastic job of addressing them in real time and really getting things changed, that you form your strategy around what your employees' needs are. So that's to be applauded. But as you learn from all of this, I think we all understand that our approach to behavioral health and mental health conditions has to be ever changing, first of all, because it just keeps changing. But it also has to be forward thinking. Access is not going to change in the next 5 years. We're not going to solve this. There's no government program that's going to come along and say every provider has to be in a network. Every provider has to take insurance. Every provider has to say yes to every patient. That's not going to happen. We don't have a magic wand here. So what can other employers do as we look around the corner going forward to really prepare for the fact that this is here to stay? It may even grow as people realize that they can say they need help. How do they prepare themselves for that? And what can they do? What can they do to help them decide on which products and programs will be best for their population?
That's a big question.
I know. Crystal ball.
With a
You
lot,
don't have your crystal
yeah.
ball sitting there?
Yeah, here I say. So I think that you're right about access not changing overnight. But as we look at what providers may be able to bring us or co-create with other providers, I think one of the immediate areas to solve for is how people can get connected to the right kind of care. So, we were very fortunate that our partners at Blue Cross created this navigation piece for us. There are other innovators out there. I don't know if you'd call them EAP replacements, but in the mental health space in some areas, kind of replacing a traditional EAP that give people the opportunity to identify specific needs that they have from if it's a therapist. By the way, they also can, on the way in, kind of show where a good starting point might be for that person. So kind of triaging over to coaching or therapy or other areas. So I think that that's the biggest thing that I can say is helping people get the right fit and the right help getting connected to these providers that have availability. It's just daunting. And the comments that we've got, and I have to say, I wish our use of the behavioral health navigation was higher, but it's a phone number still, it's not in people's palms. But the comments back from those that have used it, it's transformed people's life. People have put it off for a year, but now that this service was there to find them somebody. So I think anything we can do to reduce the friction or the challenges to getting connected and getting in for that appointment is probably where I would put my first efforts. You talked earlier about outcomes. That is so important. We're just starting to be able to see those. So I mentioned with the coaching provider, because again, with technology, and I do want to make sure that everyone knows I'm not overemphasizing technology. I think it's important to have both sides, but the gift that technology gives us is the ability when employers are in the app or the website, they'll do a PHQ-9 or a GAD-7 several times over a few months, and it gives different frames of reference so that we can compare back and see those outcomes. So that's a big benefit. The other thing I think is telehealth. It's I know I'm just whipping off a few different things, and everyone's budgets are different and strategies. So, but I do think that the telehealth is a game changer. I looked the other day, we still have 57% of our healthcare visits telehealth. So, we talked earlier, we saw, Kathryn's information, Candace talked about it. It works for people. It's not the wellness visit you do once a year with your physician. This could be every week. It could be every other week. It could be in some cases multiple times. And so for the right individual, because I don't even know that this is a generational thing. I think it's an individual thing. If you prefer in-person or virtual, that can be a game changer. So I think providing some type of the virtual help is also really, really important. Yeah.
So, and that's really good advice, because you're right. Our research shows it's not a generational thing. Very many older Americans used virtual care during the pandemic and are continuing to, as we move into our delayed care research, which we're working on now, publishing. We are finding that, as I said earlier, people are not getting back to in-person care at the rate we thought they would be. And when we are asking them why, because we're asking that question, are you going back to care in person? And if not, why? It's a whole slew of different reasons. Like I said earlier, one of them being financial. I have to choose between buying groceries or paying my deductible. I'm buying groceries, right? So we know that there are still barriers to care that existed way, way, way before the pandemic, but that have been exacerbated by the pandemic. So virtual can be sort of a stopgap, but if the benefit design has to be right too. If you're using virtual care as a stopgap, really, until people can get fully back to in-person care, it has to be financially advantageous for them to do that, right? I think that also the other thing that we didn't talk a lot about in this particular research, but that we want to understand and never forget, is that anxiety and depression are a huge comorbidity diagnosis for many of our other very high cost drivers, right? So diabetes, obesity, heart disease, cancer. Those are things that you often see, anxiety or depression or both, as a comorbidity. And so while we looked at utilization and we looked at the survey questions asked about anxiety and depression, what we didn't really dive deep into was the huge cross driver of having a disease state that is associated with a physical condition, and you also have anxiety and depression. Those are also ways that we have to start addressing the diagnosis. There's no stigma with that, right? We didn't have stigma with that. When you have cancer, of course you have depression or you have anxiety, etc. That was acceptable in the world before pre-pandemic. Now we have to really start looking at these diagnoses as a comorbidity and how we can have programs in place that look at the thing that is keeping you from getting better today, right? I may have diabetes that's well controlled, but I don't really take care or think about my diabetes because I'm depressed. And so if you don't address my depression, we'll never get to the diabetes conversation, right? So I know, Tara, you probably have some thoughts about that.
Yeah. Well, and we've seen, it was very eye-opening for me when we brought in a new coaching provider back in 2019, and we were able to offer both mental health coaching as well as physical. Everyone, if they're identified as having a need, they're offered to do concurrent mental health coaching along with, in this case, weight management. And those that accepted the help lost twice as much weight as those that didn't. So by addressing one piece, you're able to kind of blossom in life, actually. And, these things, no pun intended, weigh us down. And I think it's hard sometimes to know what to address first, or sometimes you may not even know. You're so busy getting through life that you don't even realize that you're functioning with this moderate anxiety level, or that you may have depression. It's because it's kind of just how you've been operating. And so having the opportunity to recognize that and then get support for that can really be life-changing for people. So I think you're so right. I think that we haven't looked enough at the connection between the two, and quite even further than the connection, just how dramatic the improvements and the outcomes can be when we do connect them.
Yeah, and there is data out there. Someone from the audience pointed out that MBGH and many others have done comorbidities with mental health research, and there's plenty out there. I think I just wanted to point out that we don't want to forget kind of that group of people who don't have a standalone diagnosis of depression or anxiety, but do as a result of a comorbidity. And one other question came in, is the last one we're going to answer, talking about how do you educate employees about the differences in care based on their needs, right? So do they need therapy? Do they need just coaching? Do they really need a psychiatrist, or do they need a therapist? And I will say first, and then I'm going to let Tara address this too. We don't have a system to do that works really, really well. So that's why when you go, most people's entrance point for the first time might be into the mental health world, might be through the emergency room. And in the emergency room, you see a doctor in the emergency room for, 10 minutes. And then they call in the psych counsel, and you have a 1 hour, usually video virtual visit with a psychiatrist, and they kind of evaluate you and you're off and running. You're in the system. That is for every other diagnosis. That is a huge cost driver in the insurance industry. We have a whole host of things that happen to you that tell you what you need for care. And it's a predictive model. We have a predictive model for diabetes, for MSK, for, for heart disease. We have all these predictive models that can predict if these things happen to you and you have these types of things in your diagnosis and in your blood work, here's the path you need to take. We have no predictive model for mental health. There are loads of research out there that say if a person looks like this, if they're this age, this sex, this income, this ethnicity, this, and this, they do best on the average, they do best with counseling and medication. And then this persona does best with only virtual, and this persona does best only with in-person care. There's tons of research out there. Out of Harvard has a lot of predictive model research around mental health, but we don't apply that in the insurance industry really at all. And in the clinical setting, which is where it should be applied, it rarely gets applied at all. Like I said, a lot of people just go through the emergency room and you're off and running in the system. So thank you for bringing that up, Christina. I don't think there's a one size fits all answer to this, because the system has to change for it to change. And that means a lot of constituents within the system have to change. But I can let Tara address how they're looking at it at Boeing, getting people to the right place through their navigator.
Yeah. And really quick, I do just want to go back to the comorbidity piece. So yes, there's research out there, but the challenge I would give to all of us is what are we doing to make it easy for employees to address both of them or their family members.
That's right.
Like how do we keep things together? So with that coaching, we could have not taken the mental health coaching and just brought in the physical health and then referred them to EAP. But why we didn't like that is then that's putting the onus on the employee to get something.
They'll figure it out. Right.
Yes. This is all in one place. What can we do to help employees effectively handle both areas? And then, so how are we getting employees to the right care? One thing is by bringing in the coaching option. And we have some very specific protocols in place if someone needs more intensive support than they can provide, and getting them connected over to our health plan or to EAP in order to get that higher level of care. What doesn't happen is coming down, to your point, from therapy to coaching or to self-serve resilience or something like that. As we learn more about these innovators out there in the EAP space, they are doing more of that. It always is left to be the employee choice, but in most situations anyway that I'm aware of, there may be differences, but the ones I've seen, a recommendation is brought forward. Right. And that's important for so many reasons. It's important for the costs that we're all trying to manage. We want employees to get the best care, we'll pay for it, but we want to pay for the right care. But also keeping the clinicians that we need to treat those higher acuity levels available for that. And we can do that if we help kind of get employees down the right path to start with.
Totally agree. Well, listen, Tara, Candace, Kathryn, thank you all for helping us with this webinar on this very important topic. We don't usually do 90-minute webinars, but this is a topic that we all know is so important to all employers and to their workforce. So we will continue to do our research on mental health, on behavioral health. We have another research paper coming out for 2023 on the same topic, where we'll dive deeper into some of these sort of side conversations that we had along the way throughout this presentation. We especially want to thank Kathryn and Elevance for supporting us with the claims data. It's feel like it's very effective to show both sides of the coin, where we're asking people how they feel, and then what in the claims data, what do they actually do about that in real life, and where are we seeing those play out? So if anyone has any questions about the papers, as Candace said at the beginning of the presentation, for our IBI members, this research and the slides from today are available on our website at IBI. After 3 months, they are under an embargo for members only for 3 months. It will be available publicly. We will send out to the participants today a recording of this webinar, and then you would be able to access it on the public website if you're not a member after 3 months. So we thank you all for your time. I know 90 minutes is a lot these days, but we do appreciate you joining us on this very important topic and hope you have a great rest of your day.